Hello everyone, welcome to the session on Surgery Quick Revision Series Part 3. My name is Dr. Jhanvii. I'm the anesthesia educator on Unacademy, and today we are going to be discussing Part 3, and with that we are going to be finishing the entire intestine. So on the first part that we revised, we did the small intestine and the large intestine, and the second part also involved all of those. We did different kinds of diseases like Hirschsprung's, IHPSS, and your sigmoid volvulus, all of the associated disorders. Then we had also done stomach in one of those parts, and today in part 3 we'll be finishing off with the rectum and anal canal. And I also have something special for you guys. We will be also discussing a few important signs and triads in surgery in this class. So welcome to Unacademy. I hope first of all you guys are able to see me and hear me well, and the streaming is absolutely clear. Please leave a thumbs up in the chat box if the streaming is clear. Okay, yes, I can see that the streaming is fine. All right, so before we begin today's class, a few things that you guys have been messaging me on Telegram. We had this mission FMGE. I don't know if you guys know of it. Mission FMGE Medicine in 10 days. So in that, I have taken a lot of free lectures. They are all between special classes and YouTube. So they are freely available for all of y'all. And those lectures basically are taken in on rheumat, cardio, endocrine, nephro, hepatobiliary, and what was left out of all the systems was two. One was hematology and one was CNS. So hematology, I will be taking it as a flashcard revision tomorrow for you guys at 4 p.m. That is our usual timing. And the other one that we have, CNS system, I will not be taking it because it will take me itself a lot of time to study CNS and teach it to you all, and I won't be able to do exact justice to CNS because of that. So I'm not going to be taking CNS. You guys can read it from the notes that you already have. And all of those lectures are linked on Telegram. You can get it from Telegram anywhere. It's there on YouTube also, and it's there on special class platform also. Now with regards to this surgery quick revision series, I'm going to take as many lectures as I can till the end of this month so that we can cover the whole of your surgery. Today we are going to be finishing the whole of your gastrointestinal tract, so then we can move on to urology. Okay, now the thing with today the class is at 3 o'clock because at 4 o'clock I have a important Zoom meeting, so I won't be able to take at that time. All right, and the thing with these YouTube lectures is, let me show you guys. A lot of you have been asking me for PDF of the YouTube lectures. I'll simply show you what goes wrong when we write. So the setup that we are using right now is setup called as some studio. Okay, so suppose I write over here studio setup. Okay, now you see when I'm trying to close this on my iPad, the whole thing, can you see the text has gone? So there is no text at all. So when I write the lectures for you guys, everything will be there when I write it, but the minute I close that lecture window, everything will go away. So as a result of this, nothing gets saved as text, and there is nothing that I can give you as PDF. This is actually on Keynote on the PowerPoint format, and that is exactly how the devices that I'm using are working, and that's this technical setup. So there is no way that I can give you a PDF of a YouTube class. The minute I shut this on my iPad, the entire thing will go away. All right, so if you guys want, what you can do is, while the class is going on, you can take down notes of the class. I don't write very extensive things, so definitely you can take down a few notes, or if you want for revision, you guys can watch these videos at 1.5x or 2x the speed, so that will be comfortable for all of you. All right, so let's begin with our class for today. I'm a Plus verified educator, and this is the Telegram group where you can join and get the links to all my classes. I pin all my classes in this Telegram group, so you don't even have to go through each and every message on the group. You can just tap on the pinned messages above and get all the classes. The Plus subscription on Unacademy will help you get access to live classes. You can learn from India's top educators. You can compete in live tests and quizzes. You can study on the device of your choice. The iconic subscription on Unacademy will help you get the best of both Unacademy and Prep Ladder. So you can get the live lectures of Unacademy along with the video lectures and question bank of Prep Ladder. And these are our special class features. They are interactive. We have polls for the learners. We have raise a hand option. And in the special classes on the Unacademy platform, you have this very great feature where you can download the PDF. Okay. So whenever I take a class on the special class platform, yes, PDF will be available. You can take it, the PDF from there. But on YouTube, the PDF is not available. All right. We have a highly effective question bank with 25,000 plus questions. These are our NEET PG toppers. And we have Unacademy combat test on the 28th of November at 5 p.m. for you guys, where you can win great prizes. These are a few of the plus batches that are going on. The Focus FMGE 2022 comprehensive batch, free test calendar, NEET PG 2022 batch, and next integrated 2023 batch. And if you want to buy the plus subscription, these are a few of the offers that we have. So you can get 24 months, 2 years plus 4 months free, 1 year plus 2 months free, or 6 months plus 1 month free. All right. And if you would like to buy the Unacademy subscription, you guys can use my code Dr.Jhanvi Live, with which you get an extra 10% off on your subscription. This is the code Dr.Jhanvi Live. All right. Okay. So let's begin with our class for today. The first thing that we are going to be discussing in CA rectum and anal canal. So can you tell me, guys, what exactly is this condition? You see it in the middle of the buttocks of the patient, and it is something which is infective. And if you see it microscopically, you see what is happening. There is an open tract that is leading out to the buttocks. This tract is lined by epithelium, and inside there is collection of hair inside. So any idea what are we talking about over here? Okay, so this is called as nothing but a pilonidal sinus. Absolutely correct. Abhik told us the correct thing. This is called as a pilonidal sinus. Okay, so what is a pilonidal sinus if you have to define it? So basically, if you see in this picture, it is an epithelium lined tract. Okay, and this tract is present in the intergluteal cleft. Now this tract, it is nothing but a root, and at the end of it, it has a sac. And in this sac, it contains hair and it contains unhealthy granulated tissue. Okay. Now, why does this tract form? Actually, you will see that this is present in very hairy men. Okay. Those especially who have a lot of hair over in this area, in the intergluteal cleft. So the hair will burrow a hole inside, like this tract inside, and it will sit over here in this cystic space. Okay, and this hair can get secondarily infected. So that is the problem that we have, that this sinus gets infected, the hair gets infected, and this can lead to a problem in the patient. Okay, so they'll ask you what is the common regions where you get this pilonidal sinus. So it's not just in between the buttocks, but you can also get this in the umbilicus if people have hair in the umbilicus, or you can also get it in the axilla. Okay, so these sinus tracts can form it in any of these places. Now, the next important question, if they ask you as a case scenario, what is this exactly? So in the case scenario, they will say it is common in people who are hairdressers. Okay. Now, where and why do hairdressers get this? So, in their interdigital clefts, whenever hairdressers cut, they have hair deposited over here, correct? Logo ka baal gets deposited over here. So, that hair can go through this interdigital clefts and it can form that pilonidal sinus. Okay, basically the hair cuts a root inside the skin and makes a permanent hole inside. Alright. Then, one of the important ones that most of you know about, Jeep drivers have it. Why? Because Jeep drivers who are very, very hairy, they have a lot of hair in their intergluteal cleft. When they are continuously sitting, there will be pressure on their buttocks, and because of that, the hair down will keep irritating the epithelium in between the buttocks, and then it can form a small pathway, small root, and it can lead to a pilonidal sinus. Okay, so it is very, very common in hairy men, and this is especially common in people who are 20 to 30 years of age. Okay, now the next thing that they will ask about pilonidal sinus is what exactly is the pathophysiology of it. Okay, so how does this occur? So I'm going to write it down so that you guys understand the pathophysiology. So first thing what happens is hair will penetrate the skin. So initially there is nothing on the skin. The skin is good, it's unbroken, it's intact, but slowly that hair starts irritating, there is friction, and the hair starts penetrating into the skin. As it penetrates into the skin, it leads to inflammation of the skin, that is called as dermatitis, and slowly that inflamed skin gets secondarily infected. Once it gets secondarily infected, there will be formation of a pustule, and once there is pustule formation, slowly there will be a formation of a permanent tract. So as you can see over here, there is a permanent tract, and this tract is called as a sinus. Okay, so there will be a sinus formation. Now once the sinus gets formed, what happens next? So once there is a tract, because of the negative pressure in this area, the other hair will automatically get sucked into the sinus. Okay, so hair gets sucked into the sinus, and once the sinus keeps sucking more and more air by negative pressure, there will be more irritation, there will be more pus formation, and there will be presence of more sinuses, and these sinuses are called as secondary sinuses. Okay, so this is the exact pathophysiology of your pilonidal sinus. So it's basically hair irritating the skin, creating a pathway in the skin, infecting the skin, and then finally forming a permanent root or a sinus in the skin. Okay, so the first sinus that is formed, this one, it is called as a primary sinus, and then because of the progression of the disease, the following sinuses that you get are called as secondary sinuses. Okay, or now, what are the clinical features of this disease? What will this patient present with? So from the picture, I've told you how it will present, but if they write in a case scenario that this patient is coming with what symptoms? So he'll come with a lot of throbbing pain. It will be a dull aching type. It won't be a sharp pain that will be present in the area where the pilonidal sinus is. Okay, then you will see a tender swelling in that area because the skin over there is inflamed, and you will also see discharge of pus if it is secondarily infected. Okay, then the next thing is, how do you differentiate between primary sinus and secondary sinus? So I told you primary sinus is the one here. You can see primary sinus is the one where the hair first starts going inside and it forms a tract. Secondary sinus is formed because of negative pressure and absorption of more and more hair into the tract. Okay, so your primary sinus will always be in the midline and your secondary sinuses will be in the side. Okay, so that is how you can identify between primary and secondary sinus. Primary sinus will always be in the midline, in the intergluteal cleft, and your secondary sinus will be in the paramedian position. Okay, now next thing that they can ask you about this is, what is the complication of this disease? So first thing, you already know that what is it? It's basically getting infected. So if it is infecting the skin, it can also start infecting the bone underneath. Okay, so when it starts infecting the bone underneath, what is the bone in the area of the buttocks? That is the sacrum. Okay, so there can be sacral osteomyelitis, and you can also have complete gangrene of that infected skin. So you can also end up having necrotizing fasciitis. Alright, so these two are the complications of your pilonidal sinus. Now the last thing that they will ask you is, how do you treat it? Okay, so treatment is for two things. One is for the acute phase and one is for the chronic phase. So in the acute phase, you cannot do any kind of surgery because it is infected. So you will first drain the pus, and after that you will start the patient on antibiotics. Okay, just drain the pus and start on antibiotics, and then later on, when the patient comes after 6 weeks of antibiotics, you can do a definitive surgery. Okay, so what is the definitive surgery? This is the question that they ask in the jackknife position. Surgery is done in a jackknife position. So in a jackknife position, patient is in the lateral position and his one buttock is up and the lower limb, one dependent limb is down straight, and one buttock is completely up like that, and the knee is flexed. Okay, so that is called as the jackknife position, so that the intergluteal area is exposed. So in the jackknife position, you will remove the sinus tract completely. So you will do excision and closure of the sinus tract. Remember, you have to completely remove the sinus tract. So you have to excise the entire sinus tract. You cannot just leave it just like that over there. Otherwise, the negative pressure that it creates can cause more and more hair to come inside. So it will become a recurrent disorder. All right. So this is everything about pilonidal sinus that you need to know. So we've seen the location where the pilonidal sinus is. Then we've seen this area where it is present. How does it look like? What is the micro picture of pilonidal sinus? What is the pathophysiology, in whom it is common? What are the clinical features, complications, and the treatment of pilonidal sinus? So is that clear for you guys? Please leave a thumbs up in the chat box if what I'm saying is making sense. Otherwise, I don't understand whether you guys understand or no. If you have any doubts also, you can ask me. And now let me show you guys the magic because of which most of you are brickbatting me on Telegram saying, ma'am, you're not sharing PDF, you're not sharing PDF. Now see, I have written so much, okay, about the disease. Now the minute I stop this, the minute I minimize it to close the application, everything that I have written is gone. So you can see on your own, everything that I have written is gone. So there is no way that I can share a PDF of the same for you. It is possibly possible in Windows laptops, but I don't have a Windows laptop, and maybe that's why I'm getting all these problems, because the application in my laptop opens in a different way. All right. So if you guys want, you can definitely take down notes while I'm teaching, or the smarter way, the Gen Z way, is to just watch at 1.5 or 2x the speed to revise it. All right. Okay. Now, what is this other thing that you can see over here? This is the next disease. So this is your dentate line, and you can see there is a collection over here. These are basically your anal cushions, which are nothing but aggregations of blood. So can you guys identify what is this? These are your anal cushions which are coming down. One is over here and one is over here. So you have internal and external. Yes, these are hemorrhoids. Okay, these are hemorrhoids. So in hemorrhoids, the first thing that you need to know, one second, I'll just write it again. The first thing that you guys need to know in hemorrhoids is what are anal cushions. Okay, because the whole point about hemorrhoids is the anal cushions. The whole anatomical problem is the anal cushion. Okay, now your anal cushion is nothing but it's an aggregation of 2-3 things, of blood vessels, so your arterioles, venules, of smooth muscles, of your elastic connective tissue. Okay, so these are your anal cushions. They are an aggregation of your smooth muscles, elastic tissue, and blood vessels. All right. Now, what happens in case of hemorrhoids? In case of hemorrhoids, this anal cushion gets pushed down. Usually, it is above the dentate line, but when you strain, okay, when you are constipated and you strain a lot and there is chronic straining, there is downward sliding of these anal cushions. Okay, so you have two types of hemorrhoids. One type of hemorrhoid is when the anal cushions come down, but they are still above the dentate line and they are covered by the mucous membrane. Okay, that is your internal hemorrhoids. The second one is external hemorrhoids. So in external hemorrhoids, what you have is that your anal cushions will come below the dentate line. Okay, so that is your two important differences between internal and external hemorrhoids. So your internal hemorrhoids, what is the problem? You are having anal cushions above dentate line. Your external hemorrhoids are below dentate line. Okay, then this internal hemorrhoids are covered by mucous membrane, and your external hemorrhoids are covered by skin. Okay, you can see it from the picture only over here. Your external hemorrhoid is covered by skin, Internal hemorrhoid is covered by mucous membrane. Alright, so these are your first two differences between hemorrhoids. Then your next difference between hemorrhoids is what are primary and what are secondary hemorrhoids. Okay, so now when you look at the anal cushions, okay, I told you everything is about the anal cushions. Now these anal cushions are basically located in three positions always. Okay, so one is at the 3 o'clock position, one is at the 7 o'clock position, and one is at the 11 o'clock position. This is in the rectum. Okay, sorry, in the anal canal. So in at 3, 7 and 11 o'clock position, you have your position of the hemorrhoids. So these are called as primary hemorrhoids. Now, what is so great about this 3, 7 and 11 o'clock position? Can anyone tell me? What is so specific and great about this 3, 7 and 11 o'clock position? Why am I focusing on this? Okay, so these positions are related to the branches of the superior hemorrhoidal artery. Okay, so your superior hemorrhoidal artery, it will divide and give off three branches. One is at the 3 o'clock position, one at the 7 o'clock position, and one is at the 11 o'clock position. And that's why you have these primary hemorrhoids located at these different positions. Okay, and your secondary hemorrhoids are the ones that occur at any other site. Alright, so in between over here, anywhere your secondary hemorrhoids can occur. So this is your next classification. So we have done the first classification, that is of internal and external hemorrhoids. Correct? Then your next classification is primary and secondary hemorrhoids. Then your third classification is first degree, second degree, and third degree and fourth degree hemorrhoids. Okay, this is your next classification: first degree, second degree, third degree, and fourth degree hemorrhoids. All right, now what do you define each of these by? So here you have bleeding hemorrhoids in first degree. So there will be blood that will be present when the patient tries to pass motion. Okay, but the hemorrhoids as such will not come out. You will not be able to see the prolapsed hemorrhoids. Okay, then your second degree hemorrhoids are the hemorrhoids that will prolapse during defecation, but after that it will return back spontaneously. Okay, so only during defecation you will be able to see them coming out. Okay, then your third degree hemorrhoids are the one that prolapse during defecation, but they will not go back on their own. So as a result of it, you will need manual help to push them back. So you will have to put your finger inside and push the hemorrhoids back. Okay, and your fourth degree hemorrhoids are the ones that are permanently prolapsed. Alright, so whatever you do, even if you try to put your finger inside and push it back up, there is going to be no difference. Alright, so these are the three different classifications of hemorrhoids that you need to know: internal hemorrhoids, external hemorrhoids, primary hemorrhoids, secondary hemorrhoids, first degree, second degree, third degree, and fourth degree hemorrhoids. Is that clear? Okay, now next important thing, I'm sure all of you can tell me what are the causes of hemorrhoids. I want you guys to participate now and tell me what are the causes of hemorrhoids. Anyone? Okay, so I told you that the anal cushions are coming down, correct? So when do the anal cushions come down? When you are straining during defecation. When you have chronic constipation and you're continuously straining, that is the time when you have the anal cushion sliding down. Okay, so people who are straining during defecation, people with constipation, people with hard stool, and all these is usually seen in people who have low fiber diet. Okay, then it is, sorry, see, everything is gone. So causes we had already discussed. I'll add to it. It is also seen in case of pregnancy, and it is also seen in case of portal hypertension. Okay, along with constipation and straining. Then weightlifting, absolutely correct. That it's seen in weightlifting also. Now, what are the clinical features? How will the present patient present. Now this is a very classical term that they use. There is a splash in the pan. Any idea what is a splash in the pan? Splash in the pan means there will be sudden bright and red blood that will go into the toilet during defecation. Okay, it will be bright red and fresh because I told you it is coming from the anal cushions, and the anal cushions contain arterioles. So it is arteriolar bleeding. Okay, the branches of the superior hemorrhoidal artery. So the first important term that they use is splash in the pan of bright red and fresh blood. Second thing is you can feel a mass through the anus. So that prolapsed mass can be felt, it can also be seen through the anus. Then because of the mass present through the anus, you will constantly have a mucoid discharge present. In that area, you will also have irritation and pruritus present. Then you can have pain, you can have anemia because of the blood loss, you can have secondary infection. Okay, now can anyone tell me how do we diagnose this disease? What is the diagnosis of this disease? Any idea? There is one instrument that we use for diagnosis. Alright, so it is called as the proctoscope, correct? So we can use a proctoscope for diagnosis. Now, it is the simplest thing. You ask the patient to just relax. You put lignocaine jelly in the area where you're going to insert the proctoscope, and then you insert the proctoscope. When you insert the proctoscope inside, you will see the hemorrhoids prolapsing out or coming out into the proctoscope. Okay. Now, suppose you think that there is some cancer or malignancy associated with it, then instead or after proctoscopy, you can even go for sigmoidoscopy or colonoscopy. Okay. Because many a times when you have bleeding through the rectum, you may just consider that, okay, this is piles. But then the patient will start presenting with symptoms of loss of weight, malaise, all of those altered bowel habits, alternating diarrhea and constipation. So you should start thinking that this could be a bigger problem. PR bleed is not something that is extremely simple as hemorrhoids in every other person, but it can also be CA, rectum or anal canal or colon. Okay. So in that case, you should go ahead with the sigmoidoscopy or colonoscopy. Now, treatment for hemorrhoids. Can anyone tell me what is the treatment? What is the non-surgical treatment and what is the surgical treatment? Non-surgical or non-medical? What is the medical treatment and what is the surgical treatment? All right. Yes, we are back. So, this is the non-surgical, medical and the surgical treatment. Okay, you guys are able to see me, correct? Is the streaming okay now? All right. Yes. So we can begin. So you have non-surgical, medical and surgical treatment in case of your hemorrhoids. Okay. So in the non-surgical treatment, basically you have your diet. You are able to see me, correct? Okay. So in this diet, you are supposed to increase the dose of laxatives that you take. Okay. And anything that forms bulk, like fiber-rich food should be eaten. Okay. Then the next thing that is possible, you can do for the treatment of the hemorrhoids, and that is your sclerotherapy, cryotherapy and banding. All right, so these are all the options that we have regarding our hemorrhoids. All right, so we've discussed everything regarding hemorrhoids, how to diagnose it, what is the treatment, what are the causes, what are the clinical features. So all of that is sorted for the disease. Okay. All right. Now next we can move on to the next disease, and that is this. So what is it? It is nothing but fissure in ano. Can you see this part over here? You can see the skin over here is broken, and you see a small ulcer that is present over here in the broken skin. Okay, so what is this ulcer that is present in the broken skin called as? This is called as fissure in ano. Alright, now what do you know about fissure in ano? First of all, you need to know the definition. Nothing but it is an ulcer that is present in the lower anal canal. Okay, as simple as that. It is an ulcer present in the lower anal canal. Now, what is the location? That is what they ask commonly of this fissure. So, in this location, it is mostly in the midline, as you can see over here in this picture, and it is mostly posteriorly on the posterior wall. Okay. If you see in men, it is present on the posterior wall. If you see in women, it is present on the anterior wall. Okay, so this is the location for fissure in ano. Then they will ask you what are the causes of a fissure. So now why is this ulcer basically formed? This ulcer is formed whenever you have hard stool that passes down. Okay, now what happens is, you know that there is a curvature of the sacrum and the rectum like this. Okay, so when the hard stool passes down from this curvature, it will cause a tear in the anal valve and it will lead to formation of a fissure. Okay, so the causes for fissure is first hard stool, second it may be because of increased sphincter tone, third it may be because of trauma, okay, and fourth it can also be in case of sexually transmitted diseases. So these are all the causes of fissure in ano. All right. Now, the next thing that you need to know are the types of anal fissure. So, you have acute anal fissure and you have chronic anal fissure. Alright. So, in acute anal fissure, what is the problem? It is obviously a very fresh ulcer that is formed, and it is a deep tear in the anal skin. Okay, now this is acute, it is extremely painful and it can lead to severe constipation in the patient. Okay, on the other hand, when you have a chronic anal fissure, so patient has it since a long time, so what happens in this case? It is inflamed and granulation tissue is formed, so it is inflamed indurated scar tissue. Okay, it's basically from an ulcer become into a scar. So this is not very painful, and the patient can actually go about his normal defecation without having much discomfort in case of a chronic anal fissure. Now, how do you diagnose between an acute anal fissure and a chronic anal fissure? So can anyone tell me there is one thing that will help you diagnose in between acute and chronic anal fissure. I think I have a picture of it also. Okay. Can anyone identify what is the small thing that is present at the end of the ulcer? It helps to diagnose between acute and chronic anal fissure. What is it called? Yes, absolutely correct. This is called as a sentinel pile. Okay. So what exactly is a sentinel pile? And it is seen in case of a chronic anal fissure. So what is a sentinel pile? We'll see ahead. But before that, you need to know what are the clinical features in case of fissure in ano. Okay. So the first clinical feature that you see is pain. I told you the acute type will be extremely painful, and because of this pain, they can have a sphincteric spasm. Okay. So the external anal sphincter can go into spasm and cause more difficulty in passing stools in the patient. Okay, so whenever the patient is going to go to the washroom, he will feel extremely anxious because of the pain and the sphincter spasm. So because of that, the patient will get constipated. Okay, then along with constipation and pain, he can also have bleeding from the ulcer. Okay, and how will you diagnose this ulcer? So for the diagnosis, again, just like we did for hemorrhoids, it's very simple. You require a proctoscopy. But now what is the problem? This is very painful, So the patient will not agree to doing a proctoscopy. Okay, the minute you touch the patient in that area, he will start crying with pain. So what do you have to do over here? You have to give him sedation, or you have to give him general anesthesia to carry out the proctoscopy. Okay, now what is the treatment in case of fissure in ano? So we do something which is called as a Lord's dilatation. Okay, so you have to make sure that you dilate the area so that the stool passes normally from it, and you have to relax the sphincter also. Okay, so using 4 fingers of each hand, one side 4 fingers, one side 4 fingers, you will insert it. First you will ask the patient to relax, then you can even carry this out under general anesthesia. The surgeon can put 4 fingers of each hand and he can cause vigorous stretching of the anal canal. Okay, so that will help in dilatation of the anal canal. Then other than that, what are the other medical or non-surgical treatment? Of course, you can give stool softeners to the patient so that the stool passes easily. Then you can give local anesthetic agent so that when the patient passes stools, just before that, ask him to put the local anesthetic inside. All right. Next is sitz bath. Sitz bath is used for nearly all the rectal and anal canal problems. Okay, and you should avoid constipation. So having a high fiber diet will help. All right. Now, here, what is a sentinel pile? I told you sentinel pile is seen in the case of a chronic fissure in ano. So what exactly is a sentinel pile? So sentinel pile is nothing but at the lower part of the fissure, you will see that the skin enlarges and it looks like it's guarding the fissure. Okay. So if this is the fissure or the ulcer, at the lower end of it, you will see that there will be an enlarged skin tag or hypertrophy of the skin, which will lead to enlargement of the skin, and it appears like it's guiding the fissure. So that is your sentinel pile. All right. Okay. Next, the last thing that we need to discuss from the rectum and anal canal chapter today is anorectal abscess. And after that, we will be discussing some important signs in surgery. Okay. Now, this is your anorectal abscess. First of all, anorectal abscess is a loose term. Okay. So, it is a loose term for 4 different types of abscesses that you have. So, you may have a perianal abscess. I'll show you over here. In the ischiorectal area, you can have an ischiorectal abscess. In between the sphincters, you can have an intersphincteric abscess. Then you can have a perianal abscess and you can have a supralevator abscess. So these 4 abscesses are formed as a part of the anorectal abscesses. Any of these will form, any of these abscesses, if it's present, you can say that it is an anorectal abscess. Okay. So what are the common questions that they ask about it? So the first question that they ask is, what is the most common cause or causative organism of anorectal abscess? So can anyone tell me what is the most common causative organism of anorectal abscess? What is the organism that you mostly see in that area that can cause a disease? Okay, so it is E. coli. Okay. So in about 60% of the cases, the organism causing the anorectal abscess is E. coli. Okay. Now, next is, what are the common people who are predisposed to getting an anorectal abscess? So in predisposition, we have diabetics and we have immunocompromised patients. Okay, so they often get infections in these areas and they can get an abscess. What is the investigation of choice in case of an anorectal abscess? If they ask you your MRI to actually locate the abscess, which area is it in? Is it submucous or is it ischiorectal or is it perianal? To locate it exactly, you can do an MRI. That is the investigation of choice. All right. Now, the first thing out of these abscesses, I'll just briefly tell you about each in detail. The first one, the most superficial one, is your perianal abscess. Okay, so this is basically this perianal abscess. Why does it happen? So imagine that you have a thrombosed external pile, an external hemorrhoid. Okay, I told you the external hemorrhoid we saw earlier was just below the level of the skin, correct? So suppose that hemorrhoid gets secondarily infected. So that can lead to an abscess in that area. So it is called as a perianal abscess. The patient will have a lot of difficulty in sitting. That swelling will be very smooth, tender. Okay, you can just incise it and drain it. It's as simple as that because it's right under the skin. Okay. Now, the second type of abscess that we have is your ischiorectal abscess. So this area that you can see, okay, it is a pyramid shaped area that you can see over here. This is nothing but your ischiorectal fossa. Okay. Now your ischiorectal fossa lies between two important structures. On this one side you have the skin, and on the other side you have this muscle, which is nothing but the levator ani muscle. Okay. Now what is important about the ischiorectal fossa? The left and the right side ischiorectal fossa, they communicate with each other. So, suppose there is an infection in one side of the ischiorectal fossa, it can even spread to the other side. Okay. So, that is the problem with ischiorectal abscess. So, often they ask horseshoe-like abscess. Horseshoe abscess is seen in which case? So, horseshoe abscess is seen in case of ischiorectal abscess because of communication between the two sides ka ischiorectal fossa. Okay. Now, this next abscess that we have over here is your submucous abscess. So submucous abscess is the one, it will happen somewhere over here above the dentate line, and over here above the dentate line. And what will you get in case of a submucous abscess? You can have you can drain it by a simple proctoscope and a sinus forceps. So that is about your submucous abscess. All right. Your intersphincteric abscess is one of the difficult ones to drain. It will be there between the external and the internal sphincter. So about anorectal abscesses, most of the times they will ask only a couple of questions. One they will ask is what is the horseshoe-like abscess? That is your ischiorectal abscess. And the second thing that they will ask is which of these is not a kind of anorectal abscess. So you should just know the names of the different types of abscesses present in the anorectal area. All right. So with that, we complete the entire part of large intestine, small intestine, and your rectum and anal canal. And now we'll move on to a little bit about some images or signs in surgery. Okay. So I'll tell you what is the sign. You have to tell me the name of the sign in that case. All right. So now this sign is seen in case of ruptured spleen. Just if you guys know, tell me the name of the sign. So this is seen in case of a ruptured spleen. So when you try to carry out percussion in the area of the flanks, you will see that there is a dull note in the flank. And why is this dull note present in both left and right flank? Because of presence of hemoperitoneum. Okay. Now, if you try to move the dullness on the right side, the dull note on the right side, if you make the patient lateral, the dullness will move. But if the patient is made into the left side, if you try to percuss, you will feel it is dull. When you make the patient lateral, the dullness on the left side will not move. And why will that not happen? Because the blood that is present in the vicinity of the spleen, it gets coagulated. So can you guys tell me what is the name of the sign in surgery? Dull note in the flank due to hemoperitoneum seen in a case of ruptured spleen, and this dullness does not shift when it is on the left side because of the coagulation of the blood next to the spleen. So anyone, what is the name of the sign? It starts with B. Okay, so the name of the sign is balances sign. Okay, this is called as balances sign. All right. Okay. Now the next sign that we have is this is in a patient of Graves' disease. In Graves' disease, your extraocular muscle, in this sign, your extraocular muscles, they are the voluntary muscles, they are paralyzed. And if you look at your involuntary muscles, okay, so your involuntary pupillary reflex is present. Okay, so extraocular muscles are paralyzed, but the involuntary muscles are moving, and as a result of this, you get involuntary pupillary reflex and eye movements. So what is the name of this sign? No, not exophthalmos. This is called as ballet sign. Okay, this is called as ballet sign. Or okay, now anyone, what is the name of this sign? You must have seen it definitely many times. And when do you see it? You're seeing ecchymosis over the mastoid. What is the name of that sign? Grace anger, no. It is called as battle sign. Okay, this is battle sign. It is seen whenever there is a fracture in the middle cranial fossa. Alright. Now, next sign that you see over here is this. So, this is actually an ultrasonographic sign that you see in Arnold-Chiari malformation. So, you see over here the cerebellum is basically, it looks like a flattened and curved banana shape. Okay, so the cerebellar hemispheres over here looks like a flattened and curved banana shape. So it is also called as the banana sign. Okay, it is seen in Arnold-Chiari malformation. All right. Okay. Now, next sign over here. Any idea? So this is something that is seen in case of an arteriovenous fistula. So what are you seeing in this arteriovenous fistula? You're seeing basically that what you do is, this is your arteriovenous fistula, okay? You put a pressure on the proximal artery, okay? And when you put a pressure on the proximal artery that is supplying to the arteriovenous fistula, there will be a reduction in the size of the swelling, there will be a falls in the pulse rate, and the bruit that is present over the swelling, BRUIT, okay? Harsh flow of blood through the arteriovenous fistula will stop. So what is the name of that sign? It is seen in arteriovenous fistulas. That is called as your Branham sign. It is also called as Nicola-Dini sign. Alright? Okay. Now this sign, this so everyone should be able to identify. Yesterday only we did this. Yesterday only we did this one. See the colon, it is dilated and it looks like a coffee bean. Correct? So this is your coffee bean sign, or it is also called as bent inner tube sign, and this is seen in what case? It is seen in case of sigmoid volvulus. Correct? Okay. Now this one also we did yesterday only. Any idea? Again, it is used in sigmoid volvulus. And what do you see over here? You can see it looks like a bird who's catching her prey. So it is called as bird of prey sign. Okay, it is seen around the twisted part of the colon. Alright. Now, can you tell me what is this sign here and in which condition do you get it? Tapping along the facial nerve on the cheek will give you a spasm of the muscle. Yes, very good, Albi. So this is your Schwastek sign. Okay, this is Schwastek sign. Schwastek sign may you tap along the facial nerve and you'll get certain spasm of the facial muscle, and this is seen in case of hypocalcemia or tetany. Okay, or then next sign that we have over here. So can you see over here? This is the ureter, and the ureter is highlighted over here, and at the end of the ureter, can you see there is an enlargement or a cystic dilatation? So it looks like a cobra, both the ureters. What is it called? And in which condition do you see this? Yes, very good, Albi. This is seen in ureterocele. Okay, ureterocele is nothing but a cystic dilatation of the ureters at the end of the ureter. Okay, so this ureterocele is basically causing a cobra head sign. Alright. Okay, now the next sign that you can see over here, it is ecchymosis around the umbilicus. What is this ecchymosis around the umbilicus called? Yes, very good BPR. So this is called as your Cullen sign. Okay, and Cullen sign is seen in which case? It is seen in ruptured ectopic pregnancy. It is also seen in hemorrhagic pancreatitis. Correct? Okay. Now, the next sign that you get over here, where your bowel is looking like a coiled spring. This is called as your coiled spring sign. In which condition do you see the coiled spring sign? Whenever your barium passes through the bowel, in case of this condition, it will pass like this, like a coiled spring. So what is it called? The disease in which you get this? Yes, very good. Coiled spring sign is seen in intussusception. Excellent. Okay. Now, the next sign that we have over here. So, I don't know if you guys are able to see this properly or not, but can you see only the left side of the colon is seen? The right side of the colon is not seen. All right. So, there is no gas, no feces that is present in the colon on that side. So, this is called as a colon cutoff sign. Colon cutoff sign. And this colon cutoff sign is seen in which case? It is seen in acute pancreatitis. Okay. Now, next one, this is very easy. You tell me the diagnosis. There is gas under the left hemidiaphragm. There is also gas under the right hemidiaphragm. What is the name of this sign? And in which condition do you see it? Mustard sign, yes, that is one of the names. The other sign is a cupola sign. Okay. The other name for it is cupola sign, and it is seen in case of pneumoperitoneum. All right. Okay. Now here you can see the patient is having varices around the umbilicus. Okay. Now in this case of varicose veins or varices, if you ask the patient to perform a Valsalva maneuver, or if you ask him to cough, there will be a jet of blood that will enter this entire varix. So what is the name of that sign? I don't know if that is too difficult for you all, but it's actually asked in your exam. So if you ask the patient to cough or to perform the Valsalva maneuver, there will be jet of blood in the varix. Any idea what is the name of that sign? It is called as Krug-Weiler sign. Alright. Okay. Now next sign. Next sign is this one. You see discoloration near the inguinal ligament. Ecchymosis near the inguinal ligament. It is seen in case of hemorrhagic pancreatitis. Like we saw Cullen sign around the umbilicus. This is ecchymosis around the inguinal ligament. Any idea what is the name of this sign? This is called as Fox sign. Okay, that's why a fox is drawn over here. This is called as Fox sign. Ecchymosis near the inguinal ligament. All right. Okay. Now, if you have ecchymosis in the flanks, then what is the name over here? Ecchymosis in the flank is called as Gray Turner sign. Correct? Again, this is also seen in acute hemorrhagic pancreatitis. So you see Cullen sign, you see Fox sign, and you see Gray Turner sign in that. Alright. Now, next sign. So can you see what is this person doing over here? He's flexing the foot of this patient. Okay. So if you hold the leg like this and you flex his foot suddenly, aisa. Okay. So he'll get excruciating pain in his calf. What is the name of that sign and in which condition do you get it? So on dorsiflexion of the foot, you get deep pain in calf. What is it called? It is called as Homan sign. Okay, so this Homan sign is seen in which case? It is seen in case of deep vein thrombosis. All right. Okay. Now next, this is the CT scan of a patient, and you can see there is a tumor at the 8th nerve. Okay, so this tumor is called as an acoustic neuroma. So in a patient of acoustic neuroma, you will get a sign in which there will be reduced sensation in the posterior part of the external auditory canal because of the tumor that is compressing on the facial nerve. So any idea what is the name of that sign? Anesthesia over the external auditory canal because of compression of the 7th nerve. The name of the sign is Hitzlsperger's sign. Okay, all right. The next sign that we have over here is if you see the barium enema in case of a patient of Crohn's disease. So you see that the entire colon looks like a string, correct? So what is the name of that sign? In a patient of Crohn's disease, the entire colon looks like a string. So what is that sign called as? It is called as string sign of Cantor. This is on barium enema. Okay. All right. Now next sign over here. So your McBrines point. Yesterday I was asking, so your umbilicus, your ASIs, and you make a line between the umbilicus and ASIs and mark a point at medial 2/3 and lateral 1/3 of the line. Okay, so that is your McBrines point. Now at the McBrines point, if you put pressure, the patient will get excessive tenderness. So this is seen in case of appendicitis. And what is the name of this sign? It is called as the McBrines sign. All right. Okay, McBrines sign. Now the next sign that you get over here is in case of cholecystitis, that is gallbladder inflammation. You ask the patient to deep breathly. Okay, so he'll take a deep breath and you're putting pressure on the right hypochondriac area when he's taking a deep breath. Now when he releases that breath, suddenly the inflamed gallbladder will hit against the hand and the patient will get a lot of pain. So what is the name of that sign? Yes, very good. That is called as your Murphy's sign, seen in cholecystitis because of the inflamed gallbladder hitting against the hand. Okay. All right. Now the next thing that you can see over here is if in the CT scan you look over here, this is your liver. This is your liver. And this, as you can see over here, is your gallbladder. Okay. So in the gallbladder, you are getting this Mercedes-Benz sign. So in which condition do you get this? So in your gallbladder, because of collection of air pockets, you get the Mercedes-Benz sign. So it is seen in which case? It is also called a seagull sign. It is seen in case of cholelithiasis or gallstones. Correct? Alright. Now the next sign, this patient is basically standing up like a dog. Okay. So not standing, like he's on all fours. He's on his hands and he's on his legs. And you have put a stethoscope on the most dependent part of his abdomen. And you are trying to auscultate for any kind of fluid in the abdominal cavity. So even if there is 150 ml of fluid, you will be able to identify it by this method. So any idea what is this clinical sign? You can elicit dullness in the umbilical area and you can also auscultate and hear for small amount of ascites also. So this is called as your puddle sign. Okay. All right. Now the next sign that we have over here, I think most of you all know it. In a patient of retrosternal goiter, if you ask him to raise his hands, he will get swelling of the face and congestion of the face. So this is called as your Pemberton sign. correct? Okay, then last two over here, you can see that the sternocleidomastoid on one side is very, very obvious, and this is because the trachea is deviated to that side. Okay, so there is tracheal deviation to this side, and that's why you are getting your sternomastoid sign. In the side of the tracheal deviation, you will get prominence of the sternocleidomastoid. This is also called as your trail sign. Okay. All right. Now, the next thing that you see in the tibia, you will see erosion of the proximal part in the tibia in case of congenital syphilis. So that is called as your Wimberger's sign. Okay. And last sign that we have over here. So you can see what can we see over here? This is the lung. Okay. This is the normal lung on this side. And here you see in the lung, there is a small cyst, and in this cyst you have presence of some kind of collection. Okay, so any idea what is this collection? This is nothing but a hydatid cyst of the lung. And inside the hydatid cyst of the lung, you have the daughter cysts that are floating inside the cyst. Okay, so what is the name of this sign? This is called as the water lily sign. So these are all the important signs and surgeries that you guys should be aware of. Your water lily sign, Wimberger sign, trail sign, then you have Pemberton sign, puddle sign, Mercedes-Benz sign, you have Murphy's sign, McBrines sign, string sign of Cantor. Then in case of acoustic neuroma, you will have anesthesia of the posterior or the external auditory meatus. So that will be your Hitzelberger sign. Then Homan sign seen in DVT, your Gray-Turner sign, Fox sign seen due to your inguinal ligament ecchymosis. Then in the area of varicose vein, you have Kruweiler sign. Then your pneumoperitoneum, that is your cupola sign, colon cutoff sign. Then you have your spring sign, coiled spring sign that you see in intussusception. Then you have Cullen sign, ecchymosis around the umbilicus, uretrocoelus cobra head sign. Then you have your Schwastek sign. Then after Schwastek sign, you have your bird of prey sign, bent tube or coffee bean sign. Then you have your Branham's or Nicola Denise sign. Then you have your banana sign, battle sign. And then in case of Graves' disease, you have your ballet sign and your balances sign in case of ruptured spleen. Okay, so these are all the important signs that you need to know. Then we've completed the entire rectum anal canal and the important signs in surgery today. Tomorrow we'll be doing a quick flashcard revision of hematology at 4 o'clock, and then day after tomorrow we'll start off with urology from surgery. Okay, so thank you so much for joining me today, guys. I hope you like this class. Please don't forget to leave a thumbs up at the end of it. Remember, the continuation of the series solely depends on how well you guys receive it, how many views these videos get. So if you liked it, please don't forget to share it with your friends, and that would actually help me to continue the series, or we will have to stop it. All right. So thank you so much, guys, and